So thank you, everyone. We'll get on to the first presentation, the tale of a cotton wool spot. Now, this is a 30-year-old female who presented with TB lymphadenitis, and she was started on AKT elsewhere. She primarily had a complaint of TB lymphadenitis. She had some ocular symptoms, so she was started on oral steroids. She was improved, and they were tapered off quickly. Now, when she presented to me, this is how her fundus looked. You can see, by and large, it was clear. There was a small scar temporally to the fovea, but she had a few vitreous cells. On the OCT, there was CME. There were a few snowballs, few choroiditis spots. The vision was by and large okay, not really impaired. And you can see on the angiogram that she had macular edema, diffuse vascular leakage, staining of the scars, but the right eye looked within normal limits. So she had inflammation, active inflammation, probably because steroids were tapered off early. So she was put on 60 milligrams of day oral steroids plus topical steroids, while the tuberculous ATT was continued. And slowly she improved and they all were tapered off. So over the next 2 months, this is how her fundus looked. Vision improved to 6/6, vitreous inflammation resolved, cystoid macular edema resolved, snowballs resolved, and you can see a few scars along the periphery. And this is how her fundus photo looked. So 2 months later, and she was off steroids, of course. She came with slight blurring of vision. Pupils were normal, few cells, and she was using topical some treatment for her hairs. And this is how her fundus looked. So you can see that there is a grayish white patch just close to the optic disc, and of course close to the fovea as well. Fuzzy margins, don't know what it could be. So it looked like a small cotton wool spot. And we doubted that, okay, is this inflammation coming back? So we got an angiogram done. Well, angiogram showed just a blocked fluorescence in that area, really not significant amount of inflammation. And so we were thinking, what is this? So if you look at a cotton wool spot, let's think of a differential or how to work out a cotton wool spot. But usually you see them in multiple, numbers, and they would be peripapillary or somewhere on the posterior pole, majority of them on the posterior pole. So we look at how, you look at the vascular signs, if there are AV nicking signs, if there are any microaneurysms and everything. So on the left side of the screen, you have all the differentials which have my cotton wool spots associated with vascular changes. And then you have that differential diagnosis. On the right side, this mostly you can see single spots or rarely a lot of multiple spots. And if there is significant vitritis or overlying vitritis, this is the differential diagnosis. So we went looking on, of course, for any inflammation. And so why did this isolated kind of a cotton wool spot appear? We did an angiogram immediately, no inflammation. There's no localized vitritis over that lesion. So is this a retinitis? No one knew. So we immediately got the workup done, the vascular workup, blood pressure, sugars, homocysteine levels, everything turned out negative. She was otherwise normal. Toxoplasma IgG and IgM was done because we thought, are we missing some retinitis or atypical kind of a toxo? But it was normal, negative, both of them. She did not have fever, of course, but we did a dengue and a chikungunya serology, both of it turned out to be negative. And while we kind of were investigating all these things, this is the day 1 of the photo, and you can see that spot there. On day 6, you can see what happened, that the cotton wool spot kind of got more fluffy. Now you can see more localized vitritis over that lesion. And she had a branch retinal artery occlusion. And of course, her vision in that quadrant went down. So repeat toxo IgM and IgG was done, but again, negative. There was no contact with his cat. Bartonella serology was negative. So immediately after she developed a BRAO, started on treatment with Ceptran, Doxy, and of course, oral steroids. And now you can see how it progressed over a period of time after starting on treatment. She recovered over the next 6 weeks. And you can now see, looking at the final picture, sorry for that, you can see the final picture, and it was, in fact, probably it looked like a retinitis that kind of showed that it is something like a cotton wool spot to begin with. So the discussion is that the first episode of inflammation related to TB was untreated, The second episode is distinctly different from the first. Both the episodes responded well to the appropriate treatment at those stages. Could they coexist? We don't know. And could they overlap? We don't know. But this is how the tail ends of the cotton wool spot. Thank you so much. So we can go on to the discussion.
Quite an interesting case, Samyak.
Thank you, sir.
Your initial, the FFA that you did during the first episode of inflammation did show, a lot of leakage in general from all the retinal vasculature, right?
Right.
And there was cystoid macular edema.
There was cystoid macular edema.
Yeah, that particular episode resolved with steroids.
Yes, it resolved completely with steroids. Macular edema went off. And it was a quiet eye. And after the steroids were tapered off, in fact, over the next 2 months, this was a fresh episode. So,
correct.
None of such features.
There's no doubt about the fact that, we were dealing with a sort of a posterior segment inflammation, probably a vasculitis, and which recurred, had a second episode. But the second episode was a little peculiar in the sense it caused an arterial occlusion.
That's right.
But as you said, the second episode also, the treatment strategy was the same, which worked. Right? You started the patient on oral steroids and it gradually resolved.
So just to make a point that, initially when it presented it didn't look like a retinitis. It eventually developed into a retinitis, what we saw early, because she was immunosuppressed for the last 2 months. She was given steroids on a tapering course. She was immune suppressed at that point of time. So a classical retinitis was not seen. It looked like a cotton wool spot. But then eventually, 3, 4 days, 5 days, 6 days later, it turned out to be the inflammation went ahead and it turned out to be a classical retinitis. And that has been later, we checked the literature, it has been reported to happen. Such a retinitis in Toxoplasma retinochoroiditis can block the artery there. So, we have to see, take it in the context of the patient. How, what was the status of the patient, the immune status of the patient.
Samyak, and it's not typical chiari arthritis.
No, it is not.
There is box scarring over there. And could you manage to get a OCT over the lesion? Because some toxo lesions are now being said to be having typical OCT features. So was it possible to image?
Yes, we did get an OCT. And so when we got the OCT, it had typical that retinitis kind of a feature, that hyperreflectivity in the retinal layers. It wouldn't penetrate beyond the it wouldn't penetrate beyond the choroid. And classically, and it had this classical number of vitreous cells over that lesion. But that appeared later.
Okay.
When it occluded the artery, at that point it appeared.
So to make a point for everybody, that OCT features of a toxoplasma lesion are very classical, and one may read up that, and that can also give a clue to the diagnosis.